Hello and welcome everyone. It's my pleasure to welcome you to today's webinar on Now is the Time to Press Play on Safety Conversations. I'll begin with a couple of housekeeping notes. The session is being recorded today, and we are pleased to offer French simultaneous interpretation for this session. If you wish to hear the voice of the interpreter, please select French from the interpretation menu at the bottom of your screen. Si vous veuillez entendre aujourd'hui en français, veuillez sélectionner français ou French du menu d'interprétation au bas de l'écran. If at any point you need support during today's webinar, you can reach out to our tech support using the chat feature. Participants may also choose to view the auto-generated live captions throughout today's session by clicking the Show Captions or CC button from the Zoom menu at the bottom of your screen. Auto-generated French subtitles can be viewed live by selecting French from the translated captions list in the Show Captions menu. We are pleased to make both English and French captions available on the session recordings. So with those housekeeping announcements out of the way, let me introduce myself. My name is Jennifer Zelmer. I have the pleasure of being the President and CEO of Healthcare Excellence Canada, and I'm pleased to be your host for today's webinar. I'm joining today from traditional unceded Algonquin territory near the place where the Ottawa and Rideau rivers meet, which has been a place of exchange, of sharing, of connection for a very long time. And we're pleased to continue that tradition today in this virtual way, connecting with all of you. And I invite you to take a minute to introduce yourself in the chat so that we have everyone knowing who's on the line with us today. For those of you who don't know, HEC is a new organization launched in 2021 with a relentless focus on improving healthcare safety and quality with and for everyone in Canada. And so we're delighted to be able to wish you today happy Canadian Patient Safety Week and to have today's panel discussion being just one of the many virtual events, resources, and opportunities available to mark this week. Canadian Patient Safety Week is a pan-Canadian annual campaign that started in 2005 to inspire extraordinary improvement in patient safety and quality. This week is a partnership between ourselves at HEC, Patients for Patient Safety Canada, and the Health Standards Organization. It runs all week, and this year's theme is pressing play on patient safety on safety conversations, and with a particular focus on the safer care of older adults through safety conversations and actions. Because we know that everyone wants and deserves safe care. But even before the pandemic, safe and high quality care wasn't a reality for everyone in Canada. And COVID-19 certainly exposed some stark gaps in the health system as well. And the reality is health systems across the country and around the world continue to be under strain. So that makes it even more important than ever that we focus on patient, resident, and client, as well as provider safety. And we see this in the data. So according to the recently released hot off the presses data from the Canadian Institute for Health Information, hospital harm has grown over the last couple of years. Currently, 1 in 17 hospital stays involved unintended harm, and this is the second straight year of increase. Rates were mainly driven by healthcare and medication-associated conditions and infections. And we know that safety challenges aren't limited to acute care, and that there are many drivers as well of patient safety and quality. One of the ways that we can focus on safety and foster a safety culture is through safety conversations. They're absolutely key in building a positive safety culture. Healthcare providers, managers, and leaders need to be able to talk openly and honestly about all of the influences on their ability to deliver safe, harm-free care. And patients, residents, clients, essential care partners need to be free to speak up about their care and what they need to feel safe. And we know that's not always easy. So for instance, healthcare providers may not feel safe to speak up if they hear or see something that could impact safe care. According to a recently published report from the OECD, data from Canada show that only about 1 in 5 or 20% of respondents freely speak up if they see something that may negatively affect a patient. and feel free to question those in authority. So we have work to do and opportunities to improve as well. Against this backdrop, I'm so delighted to be able to welcome an amazing panel to spark our conversation today with a discussion around safety conversations and how we can build safety culture together, really embedding this view in care and in conversations about safety. And I'll invite them in a minute to introduce themselves, but if you haven't already done so, if you joined maybe a couple minutes late, I invite you to introduce yourself in the chat and provide a land acknowledgement, preferred pronouns if you feel comfortable in doing so. In addition, you can use the chat at any point in the webinar to ask questions or make comments, share resources with others on the line so that we can really make this a broader conversation. We were talking about it as sitting around the kitchen table. So we've got a big kitchen table today, and we invite you to join in today's conversation. So as we get going, I'll invite each of our panelists to introduce themselves and share their experiences with and perspectives on safety conversations. So Adele, I'll invite you to start us off. If you'd like to turn on your camera and take yourself off mute, invite you to introduce yourself and then share how you're coming to this conversation and how it's relevant for you.
Okay, my name is Adele Kopp-McKay. I'm from Yorkton, Saskatchewan. I know that that is Treaty 4 territory, but more than that, I'm sorry, I can't tell you. I should have checked that out. But I'm pleased to see so many individuals who work with healthcare across Canada involved today in something that's very dear to me, patient safety. So I'm going to tell you a bit about my husband, Elle, who and how I got involved in the Yorkton District Nursing Home Skinner Unit's measurement and monitoring safety in Canada, pardon me. And thirdly, I'll tell you a bit about our project. Now, I grew up in a large family and I had a lot of people around our dinner table, but never this many. So I think I'm a little nervous. So my journey to the position of patient and family advisor started February of 2016, when my husband, Elle, who had early onset Alzheimer's, was no longer able to be supported at home. With the help of a day wellness program and respite when needed, as well as some women that came to look after him when the day wellness was done and before I got home from work. He was 59 years old at the time, and Elle was a vibrant, energetic man who placed family above all else. We first met at a retreat in 1994, and by 2000 we were a couple. We lived together in the fall of 2002, and we were married in July of 2007. By the fall of 2008, I started to notice, and I said to his daughter, I says, you know, you need to tell your father everything 3 times, and then he's got it. And because of this, and because of the fact that his father had Alzheimer's, I suggested that he see a neurologist, and the neurologist diagnosed him with Alzheimer's. By March 26th of 2012, his Alzheimer's progressed to a point where he could no longer work, and he went on long-term disability. 4 years later, he was in a nursing home. Elle liked to move, and so one of the things that they did in the nursing home was they were worried about him being injured by falling out of bed. So they put him in a Ziggy fix, I think it's called. And he was in that device for quite some time. And I would keep having discussions with the team and saying, can we remove him from this device? Like, it seems so inhumane to have him strapped in there every night. So on finally November 5th of 2017, they did that. They put a hip thing around him. They put mats on the floor. They lowered his bed. And this picture that I'm sharing with you is the picture of Elle the next morning when I walked into his room. He was sitting with his feet dangled over the side of the bed, and he never looked so happy. I just had to take the picture. Elle passed away on February 3rd of 2018, just shy of 2 years in the Yorkton District Nursing Home Skinner Unit. He was 61. But I am pleased to inform you that the nursing home has really worked hard since this time over the last several years to remove those Ziggy straps and to remove the patient restraints for as many patients as possible by putting things in place to reduce injury. So Elle's journey into long-term care was quick. I completed the paperwork on a Tuesday, and by Thursday of that week, they had a placement for him. And because there were no beds in the Yorkton Alzheimer's unit, he was admitted into a nursing home in a community 30 miles from here. The home wasn't suitable for an Alzheimer's patient. It was like a square, and Al could just completely walk around the square and get so confused. He didn't know where his room was. He didn't like anybody taking care of him because he was just new to all of this. And Al also had Crohn's. So that put an extra, that just made it more difficult to look after his care. So we were lucky that on February 29th of 2016, I was able to pick him up from the community outside of Yorkton and move him to the Skinner unit in Yorkton. But when I picked him up, his head was hanging, his feet were shuffling, he had trouble putting his coat on, he hardly responded to our conversations. And when we arrived at the Skinner unit, and he was being admitted, the nurse, Scott, asked, why is Elle on Haldol? Haldol's an antipsychotic medication. So that night, I started my patient advocacy journey. I looked up the medication and its side effects, and Elle was showing all of them. So I immediately sent a fax to our family doctor requesting that he be taken off this medication, because he's now in an Alzheimer's unit. He doesn't need it. And I requested that he not be put on any medication unless I am informed first and it's passed by me. I just didn't understand how they could possibly make the decision to put my husband on an antipsychotic medication without informing me. So because Elle's needs were constantly changing as he declined, I requested that we have regular meetings with his care team, the Geriatric Resource and Intervention Team, referred to as GRIT, to discuss his needs. Now, you must understand my background. I come from K-12 education, and I worked with behavioral intensive needs students. And we had case conferences. We had mega case conferences for our students. So I didn't feel that this was out of the question to have them around Elle's care, but it was quite new to the healthcare team. So I brought with me a form that we used to identify who was to do what before the next meeting. And the form was set up to keep track and prevent things from falling through the cracks. And it certainly proved to be helpful, and I see that they still use it today. So anytime I commented on Elle's care, the difficulty I had with locating the right people to talk to about issues, my daughter Vanessa, who worked for Health Authority, kept telling me, Mom, they're looking for patient family advisors. Why don't you join? So finally I applied, and then I found out through that they were working on this project at the Skinner unit about reducing antipsychotic medication. And I was really excited to be part of that. As it turned out, the project was much broader than that, and it focused on the presence of safety rather than the absence of harm. The project looked at strategies for educating staff and for making their work safer. And we called it the 5 I's: investigating, idea brainstorming, implementation, and integration follow-up. Our biggest finding was that we couldn't do any of that if we first didn't identify the 5 types of harm: the physical, psychological, dehumanization, overtreatment, delayed diagnosis, undertreatment, harm with transition, and hospital-acquired functional decline. So the staff would have talks in their morning walkabout. So they would meet together in the morning and they would talk about possible issues that could come up in the day and how to keep the patients and themselves safe. So our project has had success with utilizing these tools to improve the safety of both the residents and the care team, and to empower team members to make changes. As was mentioned in the introduction, a lot of times the team members that are working directly with the team see what needs to happen, but their voice doesn't get heard. And what we try to do is make their voice heard. So after our last meeting in Toronto, just before COVID's lockdown, we had the opportunity to learn from other projects. And the slide the flow chart that's there for you to look at is a flow chart that I saw Calgary had a flow chart. And I thought, oh my God, is that ever a valuable chart? Because it just identified where to go. When Elle ended up in the hospital, I was like, who do I call? If it wouldn't have been for my daughter working for health, I wouldn't have known who to call. And even while he was in the nursing home, I would go like, who's the director here? Who do I contact if I have issues? So this chart proved to be very helpful for not just for the patients and their families, but just to make life easier. It would have made my life a whole lot easier if I would have had this information when Elle first got into the nursing home. It felt like if you didn't know who to contact, then the unit didn't have any issues. And that wasn't the case. Families just got upset with trying to find out who to call, and so they would just give up. The problem wouldn't go away. It would still be there. So now patients and families don't have to figure out the organizational flow chart of the nursing home to get answers. This chart alone would have made Elle's transition into the nursing home much easier for me as his primary care advocate. So changes are happening, and conferences like this help with those changes to happen. Changes are slow, and the number of patients on antipsychotic meds in our Skinner unit has dropped because conversations are happening around what issues are going to happen today, right? If it's Mary's time to have a bath, and we know that Mary gets agitated easily, and we're low on staff, maybe we change her bath to another day so that doesn't happen. So thinking about the patient's needs, thinking about the staff needs, and having those conversations, those crucial conversations around how can we keep our patients and our staff safe. So thank you so much for inviting me to be part of this conversation. I really appreciate that.
Thanks so much, Adele. Really appreciate you sharing your story and Al's story, as well as some of the journey that you've been on as an advocate for safer care as well. We're going to take a slightly different perspective now, introducing another voice into the conversation. So, Glenn, I invite you to turn on your camera, unmute yourself, and say hello, introduce yourself, and share your perspective that you're joining this conversation from.
Thanks so much. And hello, everyone. Adele, thank you so much for sharing your and Al's story with us. I try to remember to never follow patient speakers at these things, and I failed yet again. So I'll give it my best. So my name is Glenn McRae, and I'm a registered nurse, and I'm the Executive Director for Quality and Patient Safety with Interior Health. I also have the privilege there to lead the infection prevention and control portfolio. I'd like to recognize and acknowledge that I'm calling in today from Kelowna, British Columbia, which is on the traditional and unceded territory of the Syilx Okanagan people. So, safety conversations, and what exactly are they, and why should we press play on them? I've been involved in the patient safety world as a profession since about 2001, registered nurse since, I always forget, 97, I guess it was. And I think back to one of my own experiences. I was at a walk-in clinic with my son, who was a toddler at the time, and he had an earache. This is about 17, 18 years ago. And it was getting worse and worse, and was now to the point where neither he nor anybody else in the house could sleep just because of the disruption and pain and crying. I went to that walk-in clinic and was taken into an exam room, and I told my story to the nurse. And keep in mind, I'm a nurse. And about 5 minutes later, a man walked in. He didn't introduce himself. He looked in my son's ear. He grabbed a syringe, pulled up some solution, and squirted it in. And I remember thinking, I'm not exactly sure who this is or what he's doing or what was in the syringe. And I also remember just letting him do it. I also recall being annoyed at myself for not speaking up. It was fine. It turned out it was a physician and it was topical lidocaine, and my son felt better almost immediately. But it's something I still think about. As a registered nurse who was working as a quality and safety professional at that time, I saw something I wasn't sure was right, and I didn't say anything. This was a routine encounter, a non-crisis, if you like, and it was in an environment I was familiar with. And yet, in the absence of an invitation to ask a question, I stayed silent. And if that was my experience, then I wondered how realistic it was for me to expect others to do differently. At the time, I was working on a pamphlet for an accreditation requirement that was supposed to encourage patients and families to speak up and speak out when they had concerns. And I guess I had to wonder whether a pamphlet would really work when individuals are busy, burdened, intimidated, scared, stressed. And my response was, or I said to myself, I guess, probably not. Now, the rationale related to why we should have these safety conversations are not new. In the early days of my work in patient safety, about the same time as the walk-in experience, I was introduced to a recommended practice from the Institute for Healthcare Improvement at the time called Safety Leadership Walk Rounds. And it was suggested that walk rounds would foster safety conversations. They would invite staff to bring up their concerns, that leaders would then be there to hear those concerns, and ideally they'd be able to take action to address them. So did they work? Or if you're still doing them, do they work? And I guess it depends on your perspective. In my experience, the initial efforts were prescriptive and only certain topics were permitted. They had to happen at least once a week. They should never be canceled. They had to follow a script. There should be formal written feedback provided after every round, that kind of thing, very formulaic. And the efforts did create engagement and connections, absolutely. However, they were narrowly focused on past harm at the time, as opposed to the creation of safety that Adele talked about. And staff often identified in those rounds large systemic issues, such as those related to staffing or funding or amount of beds. And they were issues that leaders knew about, were working to solve, but were not quick fixes. So there was some disillusionment in the beginning. Also in the beginning, staff were not allowed to raise concerns about their own safety, at least in my experience. These conversations were just to be about patient safety. Now most organizations, including my own, recognize that we have to discuss both concepts together. It was even a World Health Organization charter called Health Worker Safety, a priority for patient safety. And I sign on to that premise that we need both and that we shouldn't be separating them. That being said, the concept of rounds led to the development of many other and fostered many other safety conversations. Adele shared her experience with one of those conversations. One story that I recall is where a new manager formed a safety action team. And this is at an inpatient unit in a hospital I worked at. And essentially that was a committee of staff who work on the unit that would meet and they'd look at how to create safety in their area. So not just past harm, how do we create safety? The manager wasn't a participant in the committee, but instead articulated her role as being a remover of barriers for the team. That was her job. They found a barrier that she was to remove them. And what I know now that I didn't really know then was that what the manager was doing was creating space to allow these safety conversations to occur. But what it also did was create an opportunity for her to hear what was important to the team and for them to check their assumptions about what she thought was important. I'll share a quick example. And it's going to seem like a simple example, but it involved a bar-sized medication fridge in a crowded medication room. And the fridge door opened the wrong way, and it done so for years. So it opened kind of into the room, and staff had trouble accessing the medication. They couldn't easily read the labels. They had to lean over the door to pull meds out because the space was tight and the wall was in the way. And staff viewed this fridge as an example of a broken system and as an example of management not listening to them and or not caring. Yet when the issue came to the manager, it was the first she'd heard of it. The fridge design allowed the hinges to be on either side, it turns out. Staff knew this, but they felt they weren't allowed to fix it themselves. Ultimately, it took less than 5 minutes for a fix. And as trivial as that sounds, that conversation, I believe, helped positively shape the many more serious conversations that followed. When we talk about safety conversations, so many concepts come into play. Creating space, flattening hierarchy, supporting everyone in the team to use their discretion and make decisions even when they have imperfect information, and then supporting them with those decisions. And I believe we can and should be expanding those conversations, and they should be including everyone we rely on for safe care. And in particular, that includes the patients, residents, caregivers, families, communities, and other partners, whatever term they use to describe themselves, who are involved in care should be involved in those conversations. And I think it's for a pretty straightforward reason. The partners bring passion and new experience to the work we do. When we throw up our hands and say things like walk rounds, been there, done that, they don't work, or that's an old idea, tried that before, it doesn't work. Our partners say around things like walk rounds, well, take us with you on them. Maybe we'll see something different. In My Health Authority, we work with our partners across a whole range of activities, and I think many of you do as well. But they're embedded in our patient safety team. They lead our Person and Family Centered Care Steering Committee. They helped design our patient concerns and adverse event review processes, our revised ones. They teach disclosure. They've even taken the lead in writing policies that we as an organization then follow. So we continue to learn together. And if we're going to press play on safety conversations, my perspective is we need to also take the time to hear what we're being told from our partners. So with that, I'll hand it back to our moderators. Thank you.
Thanks so much, Glenn. Really appreciate you sharing both your personal experiences, and I can definitely relate to your example of the challenges, even when you're in a position of privilege, speaking up in terms of situations that may occur in your own care, the care of family members, and also of your experiences in the workplace and the work that you've been doing to build safety culture. So I want to bring our third voice into the conversation now as well. So Vivian, I'll hand over to you to introduce yourself and share the perspective that you're coming with today.
Thanks, Jennifer, and thanks to Glenn, and thanks, Adele, for sharing your experience and that of Al. So I'm Vivian Ewa. I'm a care of the elderly physician and also the medical director for facility living here in the Calgary zone in Alberta. And I would like to acknowledge that I am speaking from the traditional territory of the people of Treaty 7 region in southern Alberta. And this treaty includes the Blackfoot Confederacy, comprising the Siksika, Piikani, and Kainai First Nations, as well as the Tsuut'ina First Nations and the Stoney Nakoda, which includes the Chiniki, Baseball, and Wesley First Nation. The city of Calgary, where I'm speaking from, is also home to Métis Nation of Alberta, Region 3. And so interesting that I was going to talk about something to do with the ears, and I was listening to Glenn and I was thinking, okay, well, I will continue in that theme. And so 2 weeks ago, I showed up at one of our long-term care sites, and I was having a conversation with the family member of a resident in the center. And this was a family, this was a resident that had had trouble with her ears. She had had 2 episodes of a significant purulent discharge from the ear. And so given the concerns with possible chronic suppurative otitis media, we had the conversation about sending her out to see an ENT specialist, possibly have oral toilets, and so sort of a clean out of the ear. And so I walked on the unit, and the son looked at me and he said, Dr. Ewa, I don't really know about this ENT appointment. I mean, what are we going to achieve with that? And I took the moment to listen, which is really very important when we're talking about, press and play on safety conversation. And so I said, okay, well, let me understand, the concern here. He said, my mom won't even let anybody look in my ears. It's going to be very difficult to get her out to the specialist. And, what is a specialist really going to do? And, my mom has advanced stage dementia, and I can bet you, there will be behavior concerns. And he really wasn't keen on this whole, what he called an experiment. And so I knew I was going to be preparing for this presentation today, and it made me stop. And after listening to him, I said, okay, well, you have very good points. And I'm also concerned about the same things you're concerned about, which is how we will get her out of the facility to the ENT specialist and her ability to cooperate with any interventions there. And he said, okay, I know one of the big issues that the staff have had, and even yourself, is looking into the ears. How about we do that now? I'm here, get the machine, get the equipment, and let's just do it together. And so I quickly got the otoscope and she cooperated, and I had a good look, and you know what? And I determined we can look after this here on site. We really don't need to send your mother out of the facility. And you know what? If we do have another infection, the most important thing is, we will treat it. We'll start an antibiotic and we'll treat it. We'll use some ear drops to sort of help with that local antibacterial management. And so I think that conversation really highlighted a number of key issues. And so, whereas from a physician perspective, a healthcare provider perspective, I was worried about recurrent infections. But for the family member, he was more worried about the risk that will come with leaving the facility and possible worsened behaviors. And from his perspective, quality of life was more important, and doing what we can do really on site was more important to him. And so one of the things that we did here in the Calgary zone just before the pandemic was we looked at co-designing safety conversation tools, because one of the things that we talked about is how about being more proactive with regards to conversations. I just heard Glenn use the word formulaic type of approach, which is really related to past harm. And that's certainly the approach we wanted to take in Calgary, which is a more proactive approach. In other words, rather than focusing on preventing harm, is really looking at it as, creating that safety culture and safety environment, a situation where families and residents and healthcare providers can talk about, safety and what that means and how we can achieve that at our different sites. And so our quality service lead here in the Calgary zone came up with this, project idea about creating conversation tools that can empower our frontline workers. And so we used what we call a design thinking methodology, which include 2 phases. The first phase was semi-structured interviews and focus groups where we conducted several sessions to understand the perspectives of residents, families, and healthcare providers. And one of the interesting things about the mix of healthcare providers in long-term care is that we actually included our healthcare aides or nursing aides as they are referred to in other parts of the country. And so we wanted the voices of everyone who was really involved in that care circle of our residents. And in the second phase, we took in all these themes and came up with 2 tools that could guide and inform conversations. And you can see one of them up there, which is the Me and My Needs CAD. One of the interesting things that came out of this project, and something that sticks with me and actually really highlights the conversation I had 2 weeks ago with the resident I described, is that there are different definitions of safety. And unless we ask, listen, we will probably not understand where our residents and families are coming from. And so that for me was a big takeaway. prior to this project, I as a physician and as a medical director in facility living, and my site medical directors had the impression that a lot of the safety conversations were happening formally. So in our structured annual care conferences, in our intake conferences, that sort of more formal settings. But what came out of this project was that these conversations were happening very informally. And so finding ways to support that informal conversation was a major takeaway from this project and led to the creation of the tools, one of the tools that you can see on the screen. The other thing that came out of this project was just that leadership at the site, and the fact that when there's leadership support for frontline staff and leadership actually role models behaviors that foster a safety culture, as well as have an open door policy for families, that certainly was a big driver for having these safety conversations at our site. And so it pleased me, after 2.5 years of COVID pandemic and so many things happening, this project was supposed to scale and spread to our other long-term care sites, because we started off at 2 sites and everything was put on hold as we tried to deal with the COVID pandemic. It really brought a tear to my eye when I walked onto a site and I saw what you can see at the screen. And I remember I read through it and I said, oh my God, with everything that we've gone through, this was still being used by that long-term care site as a way of initiating and fostering the conversation around safety. So you can see on that yellow block there, I feel safe when the door is locked. And so just looking at it from that resident family perspective is what is safety to you, as very different from what we as healthcare providers feel is safe. Adele described very well, how, because of concerns around fall, some people have used restraints such as, the stringy straps that she described. Whereas if we step back and we look at it from not just a quality of life, but really what's best for our residents, it's really not using any of those restraints, but understanding what that unmet need is and providing that need. And so as I wrap up and I speak to the present play on safety conversations, I would say empowering our frontline staff, and more importantly, also providing opportunities for our residents and our families to talk about what safety means to them and how we can meet those safety needs. And also emphasizing that a lot of these conversations are happening informally. And so if they're happening informally, then fostering an environment and a culture that encourages not just the conversations, but the opportunities to listen, and most importantly, the opportunities to act and respond to those safety concerns. Thank you.
Thanks so much, Vivian. Really appreciate you sharing those examples that bring to life the opportunities and the challenges that we face, as well as the more systematic approach that you've been looking at as well. So I invite all of our panelists now to join us around this virtual kitchen table. So turn on your cameras if you don't mind, so we're all here. And as we move into the more free-flowing part of the conversation, I appreciate that I'm seeing some questions start to pop up in the chat, which is great. I invite anyone at any point to share questions, comments, or other resources you may have in the chat in either English or in French, and we'll do our best to get to as many as we can. And feel free as well, if someone else has asked a question that you've got the answer to add in your perspectives in the chat box as well, so we can make this a broad conversation with an all teach, all learn philosophy with everyone who's on the line today. So I'm going to start with some of the questions that are in the chat, actually, so that we get right into the meat of the conversation. And one of the first questions really came up in terms of the kinds of tools we can use. And several of you shared some of the tools along the way, but particularly in the context of what we could do before harm actually occurs, and approaches that we may use from a patient perspective or from a care provider perspective, so that we're thinking about good catches and really that presence of safety, not just responding to past harm. Vivian, I know you shared one tool that you had examples of using. Are there others that you'd like to share? And then I might move backwards this time, so we're not always starting with the same person and moving along.
Yeah, so the second prototype we created, and I don't know if you'll be sharing that later, is the conversation cards. And so the conversation cards, and what was interesting is at our 2 long-term care sites that we used in the project, one site really liked the me and my needs cards, and another site loved the conversation cards. And so for the conversation cards, there are several questions to and facilitate rapport building. So one of the questions is, what went well today? So if you look at the monitoring and measuring safety system, it talks about that sensitivity to operations and to processes. And so the question of what went well today really prompts that, okay, that what's going on the site and what's happening. And then there's also the connecting, So I expect staff to. So sometimes that's from the resident or the family trying to, make that connection, So a good example with the me and my needs, I expect staff to lock my door. I expect staff to make sure my hearing aids are on. We hear that a lot, or my dentures are well fitted. And then we have the deep conversation. What we heard from some of our frontline staff, especially the healthcare aides, was sometimes it's very difficult to get into the deeper conversations, because the deeper conversations are things like, I feel guilty when, or I would like you to know that, or I feel uncomfortable. So these were a lot more difficult conversations. But we found that if we start off with the rapport building, the connecting, then we can get into some of the more deeper conversations. And most importantly, ensuring that whichever staff is starting that conversation is able to communicate with, other regulated staff and up to the physician and leadership. So again, that acting piece is, I have heard, I've listened, and who needs to hear about it in the long-term care site, so that we ensure that safety concern or issue is addressed.
Really appreciate that, Vivian. I think that gives good examples of it's not one size fits all. There's different approaches and tools that we can use to spark these conversations. Glenn, was there anything you wanted to add from your perspective of examples of tools or approaches?
Maybe one thing, and it's less around a tool or approach in the moment, and it's more around from my
Oh, Glenn, I think
one of the ways is through our
I think you may have frozen, Glenn. At least you're frozen for me. So maybe I'll pause and give you an opportunity maybe to just let your technology recover. There you go. It looks like you're back. Go for it.
Am I back? Yeah, it said, the message said Zoom quit unexpectedly. So maybe I'll send them a
Oh no, and it looks like Zoom may have quit unexpectedly again. Maybe what I'll invite you to do, Glenn, is actually turn off your camera. Sometimes it's a bandwidth issue. And while you're doing that, I'll maybe move on to another question and we'll come back to you. And hopefully Zoom will have decided to cooperate by then. And because of that, I may actually skip for a moment the technology question as well that came up, because I'm not sure technology is our friend right now. So we'll give Zoom a moment to sort itself out. I'll move on to another question. I'll come back to that one in a minute. And Adele, I was actually going to address this next question to you, if you don't mind. About the question really is reflecting the fact that it can be super hard to speak up for a variety of reasons, including concerns about, will this affect my care if I speak up? And, have you seen approaches that can help to address that kind of concern?
That's definitely a concern. You hear that so much. I heard that a lot in my profession in education. If I speak up, right, then how's that going to affect the care of my child? Or in the nursing home too, if I speak up, how is that going to affect the care that my loved one is going to receive? And, you know, it's about building relationships. So much is about building relationships and allowing people to, a lot of times when you first approach somebody about an issue, you're way up here, right? Like you're just full of steam, and the person that you're talking to needs to be able to understand that you need to vent that in order to get down to what really is the issue. And a lot of times we fail to do that. We fail to just allow people to have that moment of being angry. And it may take 1, 2, 3 meetings, a meeting with those families to get past that, where you can actually get to the real issues that need to be resolved. And you really have to not take how they're feeling as a slight against you. And you just need to get past that so that you can get to resolving the issue. And I think that's really hard. And you have to show that family that their speaking up is not going to affect their loved one's care. But that is a lot of conversations that may have to take place at a lot of different levels with that family, in order for them to feel comfortable, and with your staff as well, because your staff is going to feel the same way. We talk about empowering staff, but if you just one time say the wrong thing to a staff member who is just starting to come out and start to advocate for themselves, then bang, they're going to feel squashed, and it's going to take a long time to get back to that. So we really have to approach people without feeling that what they have to say is a slight against us, but it's a concern that they have. And I think if we can do that, we've empowered a lot of people.
Really appreciate that perspective, Adele, and love that you're bringing in your experiences from education too, because I do think there's so much of a crossover there. So thank you for that. And Glenn, it looks like you're back up. So maybe we'll come back to you, and feel free to, if you want to, weave in both your previous point, and if you've got any reflections on this question, feel free to weave those in as well.
Thanks. Unfortunately, when I came back in, I didn't catch which question was being asked here. But I'll respond to my previous question, because I think it covers off a little bit of a few of the other ones I've seen as well. And what I was talking about was that we have this formal process: patient concerns, patient complaints. I think everyone has it. One of the things we have done, and whether it was by design or just by happenstance over the years, is we combined our patient safety and our patient concerns team together. And then what we've done is embed patient or public members. Some of our volunteers like to be called patients, some like to be called caregivers, some like to be called public members. We've embedded them in our team so that when we're replying or working with individuals who have brought forward information to us, we do that together with partners who help. They check our assumptions about the response we are going to give. They help provide us context, and they also create a bit of a bridge between us and individuals who are who are raising concerns, which I think flattens a bit of that hierarchy. That also leads to doing some proactive work where we go out and seek. And I know that in recent years, there's been a lot of concern about the healthcare system and those who work in complaints. We've received a lot, but regardless, we're going out and seeking additional stories, the ones we're not hearing, whether those are from Indigenous partners or marginalized populations, and we're trying to understand that experience. And we do that with patient and family or public members or peers when we go out and do that. So that's been really, really helpful. And there's a comment about how to connect patient safety rounds and staff and patient safety. And I just keep coming back to something that's been part of my practice for years, is we try and always include our partners in our conversations, and it's not always easy. When I first introduced partners into our patient concerns work, into our critical incident reviews, our protected reviews, as formal members of the team, there was pushback from my own team because they were worried. And what they were worried about wasn't about secrets getting out. They were worried about whether they would feel safe to have conversations that included commentary about what others bring to these situations. And so it just took the creation of the space to allow it to happen for us to start seeing some better results. And that's how we ended up with patient partners redesigning or contributing to the redesign of all our policies and procedures for the past harm events, as an example. So for me, that part is what brought new life into, what you might call old science. We've been talking about a lot of this stuff since, well, for a long time. And it started to sound old to those of us who've been saying it for a long time, but adding in the other voices has brought new perspective and changed my practice.
That's fantastic, Glenn. Thanks so much for sharing that. And, I think it's so important that we think about who are we hearing from, who are we not hearing from, and how do we help to make sure that we're getting all of those perspectives in, and what are the mechanisms, like you just described, for bringing other voices into that set of conversations and decision-making as well. Vivian, I'm wondering if I can turn to you with one of the questions in the chat that was really around, we've talked about asking questions, listening, and acting. Do we need to add sharing to that dichotomy so that we're also opening up a broader set of conversations?
I totally agree about the sharing, especially things that have been learned. And I will just use the COVID pandemic as a very good example, where a lot of our processes had to change. There were lots of learnings in terms of, how we don and doff appropriately. There were lots of learnings, the presence of leadership on site. So just going back to some of the comments that the other panelists have made, and in terms of that safety rounds, huddles, we had sites where we had leaders, of the organization and site who were really present, and we found that those were the sites that did a lot better. And so what we started doing in Calgary Zone was we moved our owner-operator meeting to a weekly format, which really provided the opportunity to share some of the things that we have learned. And I think that really helped in terms of how we managed a lot of, not just the large outbreaks, but also proactively recognizing some of the recurring things with regards to large outbreaks, and sharing that knowledge so that other organizations could, proactively put in place or strengthen existing processes in order to reduce the risk of having such large transmission. So I totally agree. I think the question would be how we formally do that. The other thing we do here in the Calgary Zone is we have our quality service committee, one of the committees that was put on hold over the pandemic, but it has restarted. And so that's also another opportunity where we have owner-operators, we have frontline staff leaders, quality service leads at the different sites who can come together and share some of the experiences of how we promote safety culture, how we prevent, learn from past harms, but more importantly, anything that has worked as a site, how can we transfer that to other organizations? So I agree. I think sharing is key to how we can, as an organization, strengthen our safety culture.
Thank you so much for that perspective, and really appreciate both your commitment to sharing and then modeling the sharing by sharing your experiences of how you've actually done that as well. I don't know about you, I could continue this conversation probably for all day, but I am conscious that our time is running to an end. So I do want to give each of our panelists just a last quick reflection, a key takeaway that you'd like to share with the group. And Glenn, maybe we'll start with you as well on those last key reflections, and then I'll move to Vivian, and Adele will finish with you. So Glenn?
Thanks for that. A lot of what I've talked about today has been around partnering with others outside of the formal medical staff or staff structure to have these conversations. And I think that's critical. One of the things that I know that we're working on trying to determine is if we were in a situation in the future, pandemic or similar scenario, how do we maintain this idea that the team includes everyone and continue to be able to hear from everyone in those sorts of scenarios where we for lots of very good reasons, restricted visitation and limited conversations because of the nature of how we responded to COVID. So how do we maintain and protect and continue the voice of patients and others who are in the team in those scenarios in future? So it's something we're working on with our partners to understand about how we don't have to pause safety conversations for the next pandemic, but how we can just continue them. And I think that's how it felt to many people, as they were paused or stopped for a while. So going forward, I think we need a way to ensure that we can continue to have them, and that's where we're going to spend a lot of our energy in the near future. So thank you.
Thanks so much, Glenn. Really appreciate that. Vivian, last key takeaway.
So coming through the COVID-19 pandemic, I think a lot of us, and especially those of us in the healthcare system, are running on empty. And I think when we talk about pressing play on safety conversations, I think we need to take a pause and ask ourselves what that really means. Because that means is creating opportunities to ask the right questions, being sensitive to what we're hearing, listening, empathy, compassion, and as well as opportunities to act and moving that forward. And this is very difficult to do if you're running on empty. And so as we talk about safety going forward from what we've all gone through, and being sensitive to how we all feel going through what we have just come through, I would like to really stress to all of us as healthcare providers to take time to fill up our tanks. Really be mindful about our well-being, our state of mental health, and ensuring that when we come to work, we are in a state that we can actually be sensitive to ask the right questions and be sensitive to the needs of our residents so that we can respond appropriately. Thank you.
Thank you so much, and such important advice. Adele, last thoughts to you.
Being someone who doesn't actually work in healthcare and is coming from the outside, I never went through what you went through with COVID. I just got spent 2 months in isolation from my family because we all got COVID sort of at the same time, but we spread it over. But I really think what Vivian is talking about is really important for all healthcare workers, and that's figuring out how to fill up your own tank so that you've got the capacity to have empathy and you have the time to understand and to have those important and crucial conversations with the patients, with their families, with your co-workers. Because when you are lacking and you can't get your needs taken care of, it's difficult to be available to help take care of somebody else's needs. So Vivian, I really think that filling up your own tank is really important. And I think as healthcare providers, you all need to make sure that you're doing that. Thank you.
Thanks so much, Adele. Absolutely reinforce that. And hopefully we can all find ways of doing that together. One of the things that fills my tank is coming together. And so hopefully we can find ways of continuing to do that. And this is the point where if we were in a physical room, there would be thunderous applause. And a big thank you to all of our panelists for joining us today and everybody who's contributed in the course of the chat. So I'm afraid you'll have to imagine the thunderous applause, but it is absolutely there. And I know many people have provided thanks and appreciation in the chat along the way. We hope that you've all found this session informative, and you will receive a follow-up email link with the recording. And you'll also receive a range of resources from Canadian Patient Safety Week and opportunities that we hope you'll share with colleagues as well. You'll see some of them on the screen, quick guides, so grab and go to having safety conversations and supporting a safety culture and an engagement culture. Some new programs if you're interested in in joining in with colleagues across the country, including a Safety Conversations Action Series, new 4-month initiative to support healthcare teams to have safety conversations. This will be a virtual action series, so you can take part wherever you are. There'll be action periods, coaching, mentoring, and lots of peer-to-peer learning. You could also join in Reimagining Long-Term Care if you're in long-term care, that's focusing on building safer and higher quality care with and for people living and working in long-term care in Canada, with a particular focus on people in the workforce and on person-centered care, such as through Safety Conversations. And the window to apply to both programs closes November 4th, so we'll hope you'll join us, as well as join us for our next webinar on Safety Conversations, starting with creating a safe workforce and workplace. So feeding in many of today's conversations that will be hosted by our partners, Health Standards Organization, on Thursday, October 27th at noon Eastern Time. You can access all of these resources at safetyconversations.ca. And as we tick up to the top of the hour, a big thank you for participating today, and look forward to working with you to create safety, eliminate unintended harm, and act on and learn from experiences right across the country. Thank you so much, everyone. Have a great rest of your day.